experience mild disease. This seems to be so with the spread of the pandemic. A proportion of infected children, a small proportion, develop severe disease, often with prolonged intensive care and sometimes fatal outcome. Because of the generally mild nature of disease in children, it was thought that they could be community reservoirs of transmission in households. But emerging evidence suggests that children may not be the super spreaders of the virus as was thought earlier. In our country thus far, we have recorded 768 children under the age of 10 years who have turned COVID positive, and out of whom 4 have died. On the other hand, 430 under 5 years have been confirmed positive, with 2 dying within this age group. So you can see from these figures that, in fact, the proportion that die is very low, in line with what has been observed in other places. And since we're talking about children today, I want to discuss the issues surrounding welfare and formation of infants and children, as well as their growth and development from the time they are born. Globally, child survival remains an urgent concern. The first 28 days of life is the most vulnerable period of a child's survival. Children face the highest risk of dying in their first month of life. The global neonatal death rate is 18 deaths per 1,000 live births. And about a third of all neonatal deaths tend to occur on the day of birth and close to 3/4 in the first week of life. These findings suggest that focusing on the critical periods of birth and that immediately following birth is essential to save more newborn lives. In our country, under 5 mortality decreased by 50% since 1990. Neonatal mortality, on the other hand, has remained stagnant and as of 2014 stood at 22 per 1,000 live births. A more recent estimate by the UN Interagency Group for Child Mortality indicates that our neonatal mortality rate in Kenya rose to 29 per 1,000 live births in 2018. Not a very good indicator, an indicator that we need to work hard on in bringing down the number of neonatal deaths. Newborn deaths now account for 42% of all under 5 deaths and 56% of all infants. The main causes of neonatal mortality include intrapartum complications, birth asphyxia, which accounts for 31.6% of the deaths, prematurity, which accounts for 26%, and infections, which accounts for 15 and 15.8%. Other causes take up the 28%. There are various interventions that have been put in place to deal with these causes. First, with regard to intrapartum complications or birth asphyxia, efforts have been made to ensure availability of the basic resuscitation equipment in all facilities offering delivery services, items such as bag and mask, thermal heaters, enough warm towels, and other materials. We're also working together on ensuring proper care, comfort, and monitoring of mothers in labor to reduce incidences of intrapartum complications. The Ministry is also advocating for the establishment of newborn units in all level 4 and level 3 facilities to decongest county referral hospitals and level 5 hospitals. To improve survival rates of premature children, we are scaling up the Kangaroo mother care intervention in all counties, with at least a minimum of 3 facilities in each county able to offer this service. Currently, Kangaroo mother care is practiced in 31 counties. Efforts are also being made to ensure proper follow-up of discharged preterm babies until they attain 2.5 kilograms. The Ministry of Health has developed newborn care guidelines for hospitals and lower-level facilities to offer guidance to new mothers. At the same time, we are ensuring availability of training materials on essential newborn care for pre-service and in-service, as well as inpatient newborn care register for capturing newborn data within the unit. We have also introduced the use of 7.1% chlorhexidine digluconate for umbilical cord care. At the county level, we have placed a child health focal person to advocate for the scale-up of newborn care interventions. We are also providing technical support to the counties through trainings, mentorship, and support supervision on newborn care interventions. However, all these efforts have not gone without their challenges. First, there have been slow scale-up of key interventions such as the Kangaroo mother care, as well as utilization of the 7.1% chlorhexidine digluconate. Secondly, there has been inadequate support supervision, mentorship, and capacity building to the counties due to limited resources, among others. Early childhood development covers children aged 0 to 8 years old. Nurturing care for early childhood development focuses on the period from pregnancy to age 3, because it is scientifically proven that this is a very sensitive period for brain development. Yet in many settings, this period is not usually addressed in programming for early childhood development. In these earliest years, the health sector is uniquely positioned to provide support for nurturing care. From age 3, children move into more formal preschool settings where the education sector plays a pivotal role. Nurturing care for early childhood development recognizes that optimal development results from interventions in many stages of life and focuses on the period from pregnancy to age 3 in order to draw attention to the health sector's extensive reach and to make use of it. Nurturing care is the set of conditions that provide for children's health, nutrition, security and safety, responsive caregiving, and opportunities for early learning. Nurturing children means keeping them safe, healthy, and well-nourished, paying attention and responding to their needs and interests,